of definition, paraproteins, which is also referred to as monoclonal proteins, is also referred to as monoclonal proteins. It's called a monoclonal protein, M proteins. They are abnormal immunoglobulins, or they are immunoglobulin fragments. So they are either abnormal immunoglobulin or immunoglobulin fragments produced in excess by a single clone of plasma cells or the lymphocyte. So that's what we refer to as the paraprotein. And they may be intact immunoglobulins like IgG, IgA, IgM. Rarely do we have IgD or IgE as monoclonal proteins. Rarely. So the commonly seen one are the IgG, the IgA, and the IgM. Also, we have the free light chains. That's the fragment we are talking about now. And for the free light chains, they have the kappa or the lambda chain. So, and that one occurs in Benz-Jones protein. Benz-Jones protein. So monoclonality, that is derived from one cell clone. Now, looking at the nature and the types of paraprotein, if you want to look at it based on their structure, we have the one that are referred to as the intact immunoglobulins, like I mentioned earlier on. We have the other one that, in terms of structure, it is the light chains only that is affected. That is the kappa and the lambda. And we said that one is Benz-Jones protein, which appears in urine. See, also based on the structure, we have the heavy chain fragment only. The heavy chain fragment only, though rare, but it occurs. And that one has the alpha chain, the gamma chain, and the mu heavy chain disease. Heavy chain disease. So those are the diseases, those are the monoclonal fragments that will be identified for each of these particular diseases based on their structure. Now, looking at the causes of paraproteinemia, we realize that they are produced due to clonal proliferation of plasma cells or B cells. And they could be malignant. Malignant actually is a common causes, though there are other causes, but the common causes is malignancy. An example is the multiple myeloma, because in multiple myeloma, it is a monoclonal disease. Most common cause is IgG or IgA paraprotein. So, and then Benz-Jones proteinuria is also common in multiple myeloma. And then we also have Waldenstrom's macroglobulinemia. Waldenstrom's macroglobulinemia. In this one, it is IgM paraprotein that is implicated, and it causes hyperviscosity syndrome. Hyperviscosity syndrome, making the blood to be highly viscous. We have another type of malignancy, it's called the plasma cell leukemia. We have another one referred to as solitary plasmacytomia. Solitary plasmacytoma. And then we have the various kinds of lymphomas. All these are malignant forms of monoclonal diseases, especially the B-cell lymphomas. The B-cell lymphomas. And that is why it's very good to be very good in film reading. In film reading, some of these malignancies, some of these abnormal cells can be seen, apart from the chemical analysis to analyze them. And then we have another category of this of the causes of proteinemia. We look at malignant. Now let's look at the pre-malignant or the benign condition. The pre-malignant or the benign conditions. The first one we look at is the monoclonal gammopathy of undetermined significance. Monoclonal gammopathy of undetermined significance, MGUS. This particular disease is asymptomatic. It has low paraprotein level, and then it can progress to multiple myeloma. So that's why we call it pre-malignant. So from the pre-malignant stage, the benign stage, it can develop to the malignant stage of multiple myeloma. We also have the smoldering multiple myeloma. Smoldering multiple myeloma. This one is an intermediate stage of no end organ damage in this particular case, unlike the monoclonal gammopathy of undetermined significance that progresses to multiple myeloma that leads into organ damage. Smoldering multiple myeloma does not have end organ damage. And then the third category of the causes is called the secondary or the reactive causes. Secondary or the reactive causes. Usually polyclonal, but occasionally monoclonal. Usually polyclonal, but occasionally monoclonal. And then it's a series of chronic infections, causing chronic infections, or causing autoimmune diseases, or causing chronic liver disease, and human immunodeficiency virus infection. So clinical effect of paraprotein is that they may cause disease by hyperviscosity, especially if it is IgM class. They may cause renal disease, especially if it is a light chain nephropathy. It may cause bone destruction in the case of osteolytic lesions, and also they could result into immunosuppression in a situation of reduced normal immunoglobulin. When there's reduced normal immunoglobulin, it results into immunosuppression situation in that individual. And also the AL amyloid can also cause amyloidosis. So these are the possible diseases that paraproteins result to. Now, looking at the laboratory investigation of paraprotein, the first stage that we'll look at is the screening test, which is the common test. The first one is the serum total protein. So if the protein is increased, it's indicated. If there's a reverse apomyoglobulin ratio, it's also indicated. That is for screening test. And the second screening test is the serum protein electrophoresis. Serum protein electrophoresis, SPEP. Most important screening test. It shows a sharp monoclonal spike, M-band, I said it yesterday. It shows a sharp monoclonal spike with the M-band in gamma region of IgG and IgA, and in the beta region of some IgA. That is the screening test. Now, the confirmatory tests include one, immunofixation electrophoresis. These are the recently advanced diagnostic tools in diagnosing some of these things. The only thing that is giving me concern is that many of these analysis are not yet available in this part of the world. But it's better for us to know in case some of us travel out, and then for paper, for research work, we may have to go for the immunofixation electrophoresis, which identify type of the heavy chain, whether it is IgA or IgA, IgG or IgM, and also identify the type of light chain by the electrophoresis, whether it is kappa or lambda. And this particular immunofixation electrophoresis is the gold standard for typing paraprotein. It's still the gold standard for typing paraprotein because we see the chains that are actually involved in that particular monoclonal strain. And then we have the quantitative test. The quantitative test, we've looked at it. We're taking the screening test. We're taking the confirmatory test. Now we want to look at the quantitative test. One, we have the serum immunoglobulin quantitation. Serum immunoglobulin quantitation. This one measures the level of the IgG. It measures the level of the IgA. It measures the level of the IgM. So that's why we call it serum immunoglobulin quantitation test. And it will show the increased monoclonal Ig. It will show the suppression of normal immunoglobulin when it is carried out. We'll see the abnormal immunoglobulin, and then we see the quantity of the normal immunoglobulin. By inference, because there is increase in the abnormal monoclonal immunoglobulin, it will, by reverse reaction, adverse reaction, affect the concentration and the quantity of the normal immunoglobulin, thereby resulting into suppression of the normal immunoglobulin. Then we have what we call the light chain detection. Light chain detection. And then this one has to do with the serum-free light chain assay. In this case, we assay the light chain. And then we detect the kappa, we detect the LABA-free light chains, we calculate the kappa to LADA ratio. And in this particular diagnosis, it's very sensitive for light chain myeloma and for early disease that are also of a monoclonal origin. So that's for light chain detection method of diagnosis. And then the sixth one, that is a familiar one, is the urine examination for Bence-Jones protein. Urine examination for Bence-Jones protein. And I'm sure you remember, for us to detect the protein, you take 24-hour urine sample, you hit the test historically to a particular temperature, there will be coagulation. If you heat beyond a particular temperature, the coagulation will dissolve. And if you allow it to cool, it will also coagulate at that temperature. And lower than that, it will also dissolve. So that is a diagnostic, a particular laboratory diagnostic method of recognizing Best protein in the urine. So, and also for the urine, for the Best protein, we can also use urine protein electrophoresis. And I said earlier on, we can also use the immunophysician. So these are the 4 different diagnostic tools to specifically diagnose Best protein. 24-hour urine sample, heat test, which is historical, urine protein electrophoresis, which will show the spike, and then the immunophysician. Now, additional supportive investigation is bone marrow examination, which is not commonly done. This one, you will see increased plasma cells in the bone marrow slide, and then clonality will be also demonstrated. And then we also, occasionally, they use radiological investigation like X-ray of the skull, to identify punch-out lesions. And then the CT scan and then the MRI for bone involvement can also act as a diagnostic tools. And then we carry out renal function tests too. And then in the renal function test, we see an increase in serum creatinine. Increase in serum creatinine, it has to do with bones, and then increase in urea also. And then calcium level also, there will be hypercalcemia. These are the common diagnostic established facts. Hypercalcemia is common in these monoclonal paraprotein diseases. So, as a summary, monoclonal hemoglobin is produced by a single plasma cell clone, and their common causes are multiple myeloma, Waldenström's macroglobulinemia, or MGUS, and the major test is serum protein electrophoresis, even though the confirmatory test is the immunophysician electrophoresis. And also we have the light chains, which will either be kappa or lambda, especially in Best protein. And then the complications of this disease is renal failure, bone lesions, and hyperviscosity. So that's all I want to share with us this morning on the definition, the causes, and the investigation of paraproteins, Best protein. So now let's look at the fractionalization of protein and electrophoresis. Fractionalization of proteins and also protein electrophoresis. As the name depicts, fractionalization of protein is the process of separating plasma or serum proteins into distinct fractions based on their physical and their chemical properties. Is the process of separating plasma or serum proteins into distinct fractions based on their physical properties and their chemical properties. And these properties are their solubility, their size and molecular weight, the electrical charge that they carry, and then their affinity to specific ligands. So these are the 4 major properties that are used in the fractionalization of this protein. And this helps in the qualitative and quantitative analysis of proteins in health and in disease. Now, what are the basis of protein fractionalization? Like I said earlier on, solubility, electrical charge, molecular size, density, and chemical affinity. That is the basis. The basis are 5: solubility, electrical charge, molecular size, the density, and then the chemical affinity of the particular plasma protein that we are talking about. Now, the method of fractionalization of proteins are many. Let's take them one by one. The first one is what we refer to as the sorting out method. Sorting out method. This one uses neutral salt. Commonly used salt is the ammonium sulfate. Ammonium sulfate is an example of a neutral salt. And this particular method is based on the difference in the solubility of the proteins. So sorting out method is based on the solubility of the protein. So saturation level of protein precipitated at 50% will be globulin, but at 100% it will be albumin for the sorting out. The advantage of sorting out method is that it's very simple and inexpensive, and then it is useful for crude separation. Crude separation, though it has limitations. Sorting out method has limitation. Number one, it is not very precise, and we can understand. It's not very precise, and then denaturation may occur in the process of carrying out the investigation. So those are the two limitations of the sorting out method. The second method of fractionalization of plasma protein is what we call the isoelectric precipitation. Isoelectric precipitation. In this situation, each protein has a specific isoelectric point that is being used. And at the isoelectric point, the net charge will be zero. So there will be minimum solubility, and then that will lead into precipitation in the isoelectric precipitation. So example is casein precipitate, which precipitate at pH 4.6. Casein is an example that precipitate at pH 4.6. That's isoelectric precipitation. The third one is what I refer to as ultracentrifugation. Ultracentrifugation. In this one, the separation is basically based on the density and the molecular weight of the plasma protein. The density and the molecular weight, and then when you subject it to high-speed centrifugation, it will be separated into various levels based on their density and their molecular weight. And this one is usually used for research and then specialized protein studies. The next example method is the chromatographic method. The chromatographic method, and this one, the three different methods of chromatography are usually used: the ion exchange chromatography, the gel filtration chromatography, and then the affinity chromatography. This particular method of the chromatography method here, they are highly specific and accurate, and they are also used in research and advanced diagnostics assessment of fractionalization of plasma protein. Then the fifth method is the electrophoresis, which is the most important clinically, the electrophoresis, because this one will separate based on electrical charge and size, and they form the backbone of clinical protein analysis. Okay, it leads us to protein electrophoresis, the electrophoresis method. Subject them to charge, and then they will separate and then you're able to see, you can stain the film at the end of the day and be able to identify them based on the charge that they carry, and then using a control, and then you're able to separate them. Is most clinically important method of fertilization of protein, plasma protein. We also want to look at protein electrophoresis now in full. The protein electrophoresis is a laboratory technique in which the serum or the plasma protein migrates in an electric field, and they separate into distinct bands according to their charge, according to their size, and according to their shape. The principle is just that proteins are charged molecules, and at alkaline pH of 8.6, serum proteins are negatively charged. So when you subject this and you allow electric current to go through, the negatively charged protein will migrate towards the anode, and the smaller and highly charged proteins will now move faster than others, thereby creating a separation pattern, and then you can see the different bands. That is the major principle of the protein electrophoresis. And the type of protein electrophoresis is paper electrophoresis, cellulose acetate electrophoresis, agarose gel electrophoresis, which is the commonly used one, polyacrylamide gel electrophoresis, SDS page or capillary electrophoresis, which is a modern automated method. The capillary electrophoresis is a modern automated method of protein electrophoresis. So the normal pattern of serum protein fractions at pH 8.6 is that albumin will be 55 to 65%, alpha-1 globulin 2 to 2.5%, 2 to 5%, and a major component of that is alpha-1 antitrypsin. Alpha-2 globulin will be 6 to 12%, that is aptoglobulin and ceruloplasmin. Beta globulin will be 8 to 14%, and the major component of that is transferrin and beta lipoprotein. And then the gamma globulin will be 12 to 22%, and the major component of that is the immunoglobulin. Now, protein electrophoresis in health now. In health. Normal electrophoretic pattern is tall, sharp albumin peak, small alpha 1 and alpha 2 peaks, moderate beta peak, and broad gamma. All these appearance shows or indicates normal protein synthesis and immune function. When the albumin is peak, tall and sharp, and then small alpha 1 and alpha 2 peaks or moderate beta peak, all those are patterns that shows normal electrophoretic pattern. And then in disease, there will be acute inflammation of albumin, negative acute phase protein, thereby it will result to resultant reduction in the quantity of albumin in acute inflammation, reduction in albumin, and then there will be increase in alpha 1 and alpha 2 globulin in acute inflammation disease. And we see this often in acute infections, in trauma cases, and then in severe burns. And then the second disease condition is in chronic inflammation. In chronic inflammation, there will be decrease in albumin and also increase in gamma globulin, which should be polyclonal. The gamma globulin will be polyclonal in chronic inflammation. And it's common diseases that we see this chronic inflammation are tuberculosis, rheumatoid arthritis, and in chronic liver disease. Another disease condition is the nephrotic syndrome. The nephrotic syndrome. And in nephrotic syndrome, there will be markedly reduced albumin. Markedly reduced albumin because of leakage. Markedly reduced albumin, and there will be increased alpha 2 globulin, and there will also be reduced gamma globulin. And the reason is that there is loss of low molecular weight proteins in urine because of the nephrotic syndrome. There will be loss of low molecular weight proteins in urine. That's for nephrotic syndrome. Then in liver cirrhosis, there's also decrease in albumin, increase in gamma globulin, and then beta gamma bridging, which is a characteristic feature of liver cirrhosis. There is a beta gamma bridge when you carry out the electrophoresis, and this one is characteristic feature of a liver cirrhosis. We have another condition, multiple myeloma. In multiple myeloma, there is a normal or reduced albumin, but there is a sharp monoclonal spike of the M-band in the gamma region, and the cause is the overproduction of a single immunoglobulin, overproduction of a single immunoglobulin. And then we have another disease condition called the hypogammaglobulinemia. And in this condition, there is decrease or even absence of gamma region. And this one is seen in majorly congenital immune deficiencies and institution of a protein-losing enteropathy. These are clinical conditions that are under the group of hypogammaglobulinemia, congenital immune deficiencies, and then protein-losing enteropathy. Then dehydration is another disease condition under the protein electrophoresis. Dehydration. In dehydration, there will be increased albumin and globulin because there will be hemoconcentration. You know, dehydration results into hemoconcentration. So the clinical importance. Mr. Fasasi, Mr. Fasasi, mute yourself.
Sorry, sir.
Clinical importance of protein electrophoresis. We use it for the diagnosis of plasma cell disorders, and then for evaluation of liver and kidney disease, and then for assessment of immune status, for monitoring chronic inflammatory conditions, and for detecting monoclonal gammopathies. So that's all what I want to share with us on fractionalization of proteins, protein electrophoresis in health and in disease. So let's go to protein degradation now. We are running up gradually. Protein degradation. Which we also refer to as proteolysis. Protein degradation is also referred to as proteolysis. And protein degradation, as a matter of definition, is the breakdown of proteins into smaller peptides and amino acids. The breakdown of proteins into smaller peptides and amino acids. It is a tightly regulated process, essential for cellular homeostasis and energy production, and also essential for the removal of damaged or abnormal protein. So it is the breaking down of proteins into smaller peptides and amino acids. It is a tightly regulated process which is essential for cellular homeostasis, essential for energy production, and essential for removal of damaged or abnormal proteins. What's the importance of protein degradation? Protein degradation serves several vital functions. Number one, turnover of cellular proteins. Thereby, old and misfolded or damaged proteins are continuously replaced. They are continuously turnover of cellular proteins. So the degradation, getting the smaller units out, they are continuously replaced. The second one is regulation of metabolic pathways. In this case, enzymes and regulatory proteins are removed when no longer needed. That's another importance of protein degradation. The third importance is supply of amino acid, because when the protein is broken into peptide and amino acid will be provided. So it provides amino acid for new protein synthesis and for energy production. And the next importance is for quality control, because it prevents accumulation of toxic or misfolded proteins. So the degradation of protein prevents accumulation of toxic or misfolded proteins. So it serves as a quality control. And also it improves the immune function. It improves the immune function because it generates peptide for MHC class 1 antigen presentation. It generates peptide for MHC class 1 antigen presentation. Now, where are the sites of this protein degradation? Protein degradation occurs in different cellular locations depending on the particular protein type that we are studying or that is going to be degraded. Take for instance, extracellular proteins and membrane proteins get degraded in the lysosome of the cells. And in the cytosol, the process is short-lived regulatory proteins. The short-lived regulatory proteins are the ones that are degraded in the cytosol. The misfolded or the damaged or the ubiquitinated proteins, damaged or misfolded, they are degraded in the proteasome, inside the proteasome. And then the oxidatively damaged mitochondrial proteins, those ones are degraded inside the mitochondria, while the dietary proteins are degraded in the dietary tracts. So those are the various locations where the different type of proteins that I mentioned are degraded. Now let's consider the mechanism of protein degradation. The mechanism. For the lysosomal degradation, it occurs mainly in eukaryotic cells, and it involves acidic hydrolysis, also referred to as the catepsins, involve acidic hydrolysis, and it functions optimally at pH 5. That is, lysosomal degradation functions optimally at pH 5, and it degrades into endocytosed proteins, phagocytosed protein, and long-lived cellular proteins. And it is autophagy that is the process involved in the lysosomal degradation, which involve microautophagy, and chaperone-mediated autophagy. So those are the processes that are involved in lysosomal degradation. We mentioned ubiquitin proteasome pathway. Proteins are tagged with ubiquitin, which is small 76 amino acid protein in this major pathway of a ubiquitin protease pathway. And then the step is E1, ubiquitin is activated by enzyme. E2, ubiquitin is conjugated by enzyme. And E3, there is a ligase ubiquitin which confers specificity to the particular and short-lived proteins. That is, it removes abnormal or misfolded protein. It controls cell cycle and transcription protein. So another method of degradation is dietary protein digestion method, which is an extracellular degradation. It occurs in the stomach as is dietary protein digestion. And then the active that are involved in the small intestine in the process of extracellular degradation of a dietary protein. And that is based on the structure, protein structure, whereby misfolded protein are degraded faster, or the N-terminal rule, where certain N-terminal residues increase degradation rate, or hormonal regulation, where cortisol increases protein degradation and insulin decreases protein degradation. These are the various processes of regulation: protein structure, N-terminal rule, hormonal regulation, or the cellular stress. In that case, heat shock, oxidative stress accelerates degradation under the cellular stress as a method of regulation of the degradation of a protein. Now, what is the fate of the amino acid after degradation? Of course, once protein are degraded, the amino acid are reused for protein synthesis, and then they are also converted to energy. They are also converted to, that is the amination process, through the keto acid. That is the amination process converting amino acid to energy. And then they are also converted to glucose through the process of a gluconeogenic process. And then conversion also to ketone bodies through ketogenic process. And then the nitrogen can also be excreted as a urea. So that is the fate of the amino acid that are produced after the degradation. So the clinical significance, therefore, of a protein degradation. Disorders that are related to defective protein degradation are neurodegenerative diseases. Examples are Alzheimer's disease, Parkinson's disease, or Huntington's disease. The second category is cancer, where we have this dysregulation of proteasome activity. And then the third category is muscle wasting in the situation of cachexia, starvation, or controlled diabetes mellitus, result into muscle wasting. That's clinical significance of defective protein degradation. And then therapeutic application, proteasome inhibitors are normally used. For example, bortezomib is used in multiple myeloma as an inhibitors of a proteasome as a therapeutic application or method of treating this particular protein degradation. So this are what I want to share with us, that protein degradation maintains protein quality and the cellular balance of protein, and highly regulated and clinically significant. So that's all what I want to share with us on the protein degradation. Now let's go to the last topic in our outline, which is metabolic disorder, and then the regulation of amino acid metabolism. Metabolic disorder of proteins, and then regulation of amino acid metabolism. Metabolic disorders are diseases resulting from defects in biochemical pathways that are involved in the metabolism of carbohydrates, in the metabolism of lipids, in the metabolism of protein, that is the amino acid, in the metabolism of nucleic acid, in the metabolism of vitamins or minerals. The defects in this biochemical pathway that are involved is what we are trying to look at under these metabolic disorders. And they are usually caused by enzyme deficiencies or transport protein defects or cofactor or coenzyme abnormalities or hormonal dysregulations. These are the four major causes of metabolic disorders of a protein, amino acid, nucleic acid. And most are inborn errors of metabolism. I'm sure we must have had that. Most of these defects are inborn errors of metabolism. And usually they follow autosomal recessive inheritance. Autosomal that is the genetics now, autosomal recessive inheritance. Now, to classify these metabolic disorders, category A, let's look at the disorders, the metabolic disorders of carbohydrate metabolism. We have discussed some of them before, so I will just mention them. We have glycogen storage disease, we have galactosemia, we have fructose intolerance, and when we have lactose intolerance. These are the classified disorders of carbohydrate metabolism. The second category is the disorders of the lipid metabolism. We have also discussed this one before. We have lipid storage diseases, e.g. Gaucher disease, Texas disease. You will see that one, detail of that in the note of the lecture of yesterday. We have fatty acid oxidation defect, and then we have hyperlipoproteinemias as the disorders of lipid metabolism. Then we have disorders of amino acid metabolism. And disorders of the amino acid metabolism include phenylketonuria, PKU, maple syrup urine disease, MSUD, homocystinuria, acaptonuria, tyrosinemia, and then urea cycle disorders as examples of disorders of amino acid metabolism. We also have disorders of nucleotide metabolism, and the examples of nucleotide metabolism are gout, and then Lesch-Niemann syndrome. Lesch-Niemann syndrome, gout, Lesch-Niemann syndrome are examples of disorders of nucleotide metabolism. We also have mitochondrial metabolic disorders. Mitochondrial metabolic disorders. And then example is pyruvate dehydrogenase deficiency or Mellas syndrome. Pyruvate dehydrogenase deficiency or Mellas syndrome. Now looking at the amino acid metabolism now, which will be the last part of our lecture. The metabolism of amino acid. Why do we need to metabolize amino acid? We metabolize amino acid for protein synthesis, and then for neurotransmitters, production of neurotransmitters, synthesis and production of hormones, production of energy, and then establishing a nitrogen balance in the system. So these are the why amino acids are required, why metabolism of amino acid is needed. And let's look at the various sources of amino acid. The various sources of amino acid. Of course, dietary protein is the most common source of amino acid, dietary protein. And then endogenous protein breakdown that we've been talking about since. And then the non-essential amino acid are produced from the de novo synthesis. The de novo synthesis releases non-essential amino acid. For regulation of this metabolism, because this metabolism has to be regulated so that amino acid will not be overproduced. And then 3 major levels are used in the regulation of the amino acid metabolism. First regulation is at the digestion and absorption level. At the digestion and absorption level, proteins are digested by pepsin, by trypsin, and chymotrypsin. And then absorption occurs in the small intestine. And then transport systems like neutral AA transporters, basic AA transporters, and acidic AA transporters also are involved in the regulation of amino acids at the digestion and the absorption level. And then the common disorder at this level is what we refer to as the Arnold disease. Arnold disease is a defective transport of neutral amino acids. So that's the common disorder of the regulation of at the level of digestion and absorption. Now, regulation at the cellular, with the second level of regulation, is at the level of the cellular and the enzymatic level. And in this case, it is transamination that is involved. Transamination of the amino acid. The first step in amino acid catabolism is transamination. And the enzymes that are involved are amino transferases, either ALT or AST, either alanine or aspartate. And then the coenzyme involved is the pyridoxal phosphate, which is also referred to as vitamin B6. So at the level of cellular and enzymatic level, it's a transamination that regulates the amino acid level. And the regulation depends on substrate availability that is availability of the amino acid, and also on the reversible reactions, depending on which shift or which side the amino acid concentration shifts to. And under this regulation at cellular enzymatic level, we also have another process of oxidative deamination, oxidative deamination, apart from the transamination that we just spoke about. The oxidative deamination mainly occurs in the liver mitochondria, and then the enzyme involved is the glutamate dehydrogenase, and it produces ammonia. So the oxidative deamination of amino acid produces ammonia. How does it regulate? The regulation is activated by ADP, adenosine diphosphate, and the regulation is inhibited by ATP and GTP. So those are the things that serve as the regulative paraphernalia for the oxidative deamination process. Then we also have the urea cycle regulation, that is regulation at the level of the urea cycle. The purpose of that one is for detoxification of ammonia. It is for detoxification at the urea cycle level. It is for detoxification of ammonia. And the key regulatory enzyme here is the carboxyl phosphate synthesis. Carboxyl synthesis. And the active enzyme is the N-acetyl glutamate. And this one has a hormonal influence, because when there is increase in protein intake, this will lead to result into the urea cycle enzymes, increase in urea cycle enzyme in this particular process of urea cycle regulation. Increase in protein intake leads to increase in urea cycle enzyme. And then glucagon and cortisol will lead to increase in amino acid catabolism. So that is the influence of hormone on the urea cycle regulation. When there is increase in glucagon and cortisol concentration, then there will be increase in amino acid catabolism. So the next level is at the level of the hormonal regulation, at the level of a hormonal regulation. And as we earlier said, insulin will cause increase in protein synthesis and decrease in AA catabolism. Glucagon will increase amino acid breakdown. Cortisol will increase protein degradation. Tyrosine will increase basal metabolic rate. So now let's round up with the major disorders of amino acid metabolism, just for your knowledge, so that we can, in case we even ask you to write short notes on the major disorders of amino acid metabolism. Let's take note of this section. One is phenylketonuria, and the defect is phenylalanine hydroxylase deficiency. That is the enzyme, that is the amino acid that is deficient, and the enzyme that is deficient. Phenylalanine hydroxylase deficiency in phenylketonuria, and it is result in increased phenylalanine and decrease in tyrosine. So what are the clinical features of phenylketonuria? There will be intellectual disability. There will be intellectual disability. There will be occasional seizures. There will be production of musty odor of urine. Urine will develop musty odor. There will be hypopigmentation too. Hypopigmentation. And then the management of phenylketonuria is low phenylalanine diet. That's one of the methods of treatment. You put the patient on low phenylalanine diet, and then you supplement the tyrosine that is deficient. That is for phenylketonuria. And then we have a maple syrup urine disease, MSUD, maple syrup urine disease. And in this case, the defect is that there is a branching alpha ketoacid dehydrogenase. The defect is branching alpha ketoacid dehydrogenase deficiency. So, and then it results in accumulated AAS, like leucine, like isoleucine, and like valine. And the features of maple syrup urine disease is that maple syrup odor of urine will be recognized. And then there will be neonatal encephalopathy. In maple syrup urine disease, there will be neonatal encephalopathy. And then there will also be ketoacidosis. There will be ketoacidosis. Those are the features of a maple syrup urine disease. The next one is the homocystinuria. And the defect here is cystathionine beta synthase deficiency, cystathionine beta synthase deficiency, cystathionine beta synthase deficiency. And the consequence is increase in homocysteine and methionine. There will be increase in homocysteine and methionine in homocystinuria. And the clinical feature is that there is Marfan-like habitus, and then there will likely be less dislocation and then occasional thrombosis. Thrombosis also are also clinical features of this particular case of homocystinuria. And then another clinical condition is what we call the acaptonuria. And then the defect in acaptonuria is homogentisate oxidase deficiency. Homogentisate oxidase deficiency. And the features of acaptonuria is that there will be black urine on standing, formation of black urine on standing, and also there will be chronosis and also arthritis. These are the common features of acaptonuria. But the major diagnostic one is the black urine, formation of black urine on standing. Another one is tyrosinemia. And then we have three types of tyrosinemia. We have type 1, we have type 2, we have type 3, though the most severe one is the type 1. The most severe one is the type 1. And the features are liver failure, renal dysfunction, and rickets. Rickets in tyrosinemia, rickets. Then we also have the urea cycle disorders. Urea cycle disorders. And then the common defect is the omitting transcarbamylase deficiency. Omitting transcarbamylase deficiency. And the result is hyperammonemia. Hyperammonemia. In the urea cycle disorders, there will be hyperammonemia. And clinical features are vomiting, lethargy, cerebral edema, and even coma. So clinical significance is that there should be early diagnosis. If you carry out an early diagnosis of all these diseases, it will prevent brain damage. Early diagnosis prevent brain damage. And then newborn screening is very crucial so that they will not suffer any of the diseases we have mentioned, either phenylketonuria, either acaptonuria, other homocystinuria. So, but in this part of the world, we are still finding it difficult to develop to this level. In the Western world, they already have a screening method. The moment they give birth to a baby, a newborn, they screen them for all these diseases that we have mentioned. And then we can also have dietary therapy. Dietary therapy is another method of making sure that for that which is deficient, we can bring it as a supplement in form of a diet. It's the mainstay of treatment of this particular highlighted diseases. And then some disorders also respond to vitamin cofactors. Some of them respond to vitamin cofactor. So in summary, metabolic disorder results from enzyme or transport defect. It results from enzyme or transport defect. And amino acid metabolism is regulated enzymatically and hormonally. And then transamination and urea cycle are the key control points of metabolic disorders. And then phenylketonuria and then MSUD, maple syrup, urine diseases are classic examination favorites. Take note of that. They are classic examination. You can't afford not to have questions from this. I will give you questions from this. So please make sure you read this particular note very, very well. And then the hyperammonemia is a medical emergency. Of course, you know, hyperammonemia is a medical emergency. So, ladies and gentlemen, my brothers in the profession, my sisters in the profession, my friends of many years, this is the end of our lecture on MLS 501. Thank you very much.
Well done, sir. You are capable. God will renew your strength.
You're welcome, sir.
Thank you very much, sir.
Thank you.
God will renew your strength, sir.
Yes,
Thank
sir.
you
Wow.
so much, sir. Thank you so much, sir. Thank you so
No
plenty.
problem. So
Thank
Thank
you
I will
very,
try to
very,
get
very much,
your
you so
sir.
notes
much,
to you.
sir.
I will try to get your notes to you before the end of today.
Okay, sir.
All right, sir.
We
Thank
appreciate
you
it.
so much.
Then I've been asked to set your questions. So maybe when I finish setting your questions, shortly before the exam, we will arrange for a review so that
Okay,
I will be able to guide us appropriately.
So much,
okay,
sir. We
sir.
Thank you
appreciate
so
it,
much.
sir.
All right. So thank you very much.
We
Thank you,
appreciate it,
sir.
sir.
You too, you too, I'm speaking.
Let's wait behind colleagues, please. So good morning, everybody.
Good morning.
Good morning, Chief,
Good
sir.
morning.
Yes, sir. So good morning, yes, sir and man. So yes, please, first of all, I would like to congratulate us on the appointment of one of us because an achievement for us as a group in McFirst. In fact, two of us have been appointed as director and deputy director in the Ministry of Health. So, oríire náà ó máa kárí gbogbo wa. This one
Amen.
Chukwu, ṣebí you hear Yoruba now.
No, I don't understand. Just speak Igbo.
Okay,
After,
Kedu, as
after,
you
you
speak
are,
Igbo.
after you are in Nigeria. I mean, I mean that people don't follow for Nigerian language. Speak am.
This one that you have eaten,
Igbo
and
kan
your
tó
husband
sọ.
even get a shop inside the core of Ibadan.
Mi gbọ́ nǹkan tó sọ. Sọ̀rọ̀ Igbo.
Lè gbọ́
Igbo
around
ni.
Salvation Army to Inolende, you know they
I know
hear
even
Yoruba.
condemn solar. Anything solar is there here. Lithium battery dey. Panels of
Come
any
on,
kind.
madam, una dey organize
We,
training now.
they will pay for advertising.
Yes, so
So
let me advertise because light is there. Ó pàtàkì. Iná pàtàkì.
ó pàtàkì.
Ó pàtàkì
They will pay for it.
So please, I would like to congratulate us on that. Then secondly, we need to contribute our money for the Zoom. Ayalo na ń lò yìí o. We are borrowing this Zoom. This Zoom link does not belong to our class. It is microbiologists. In fact, it's their Zoom we've been using for the presentations. I mean the seminars. Yes, seminar presentation so
Ẹ
far.
má sọ síta o. Ẹ má sọ síta.
So because our own Zoom link was for November and December, unfortunately, it ended in January. I think January 6th.
Okay.
So we need to contribute. So it's either we do it monthly, like if you want to do it monthly, like 2,000 something, or we do it maybe bi-monthly or as we feel we can. Because we will need it now. All this revision they will do for us, we will do it on Zoom. We'll do it
Noted.
on Zoom. Please. Because even a trip, just one trip to McPherson, even for those of us that are nearest, that are in
Abdulrahman,
Ibadan.
oh yeah, Abdullahi.
Baba Abdullahi,
Aisha ńkọ́?
Abu Aisha, we are
Sorry o, mi ò tí ì mú ti máìkì mi o. Àwọn ọmọ yẹn fẹ́ lọ sí
no
mọ́ṣáláṣí
wala.
àníjàre, má dà wọ́n
So,
lóhùn.
okay, what essential? Essential. So please, even for the
Thank you, sir.
nearest of us, maybe those of us in FMC and those of us that are in Ibadan, we will still spend an average of nothing less than maybe around 7,000 or thereabout to and fro. So please, that 2,000 per month na token. So or 2,000 something. I know it's less than 5,000 for the 2 months. So please let's just pay up so that we can have our Zoom link up. Because these people might want to use it at the same time we want to use it, and it's their own. So that will put us at a loss, please. So let's do that. Then I'm thinking for chemistry, our lecturers, we should have a little contribution to thank them for their time. Maybe after the exam, or before the exam, just to encourage them. Maybe it's just to buy data and give to them, just to also encourage them too. Because they don't get paid, they get paid way after we finish each session. So that we don't, it's commitment. They are just committed to us. Please, let's look at, let's look into that and see what we can contribute toward that. So I think, and then for those of us who ought to have presented, Mr. Olo, are you on this call? I don't understand why he did not present, because he has sent in his slide second time, and the first time, fine enough, he had an exam somewhere else. But this one, I don't understand what happened. So it is not good enough. It is not good enough. So I will still speak to him personally. I wanted to call him out and ask what was the reason why he did not turn up. So I think those are the pertinent announcements we have. Ms. Okunolama.
I think Okola should forward the account number so that people will.
Yes, that's what I want to even say. Ms. Okunla should help us to, so that we can pay up by this week, so that we can have our link on or before Wednesday, if possible. Once we have the money, the subscription will be done. So I think I want to raise the case there. If we have any other information, please can we share with us, or any other recommendations? Then we should start thinking of how we are going to start our tutorial class. Since
Then
we are
let's
finishing.
remind Dr. O'Neill. I think we are still
Yes,
lagging
no,
behind.
so Dr. Oni is the only one left now.
And that of research methodology as well.
Research methodology is general.
Yeah,
At least we
are the general rep.
I know, I'm only saying it. So we should concentrate more on our own class.
I will try to.
So at least let him take us our class. Then please, if any lecturer contact us, we cannot fix lectures for Fridays. It is not good enough that we are having lectures almost all throughout yesterday. It's not good for our eyes. It is also strenuous that from 12 o'clock we'll be in class all through to around 7:30, 8 o'clock. I know we are trying to cover ground, but
after 9 o'clock.
because if Dr. Amuson has also decided to take us, we'll still be in class till around that 9:10. From 12, that's 10 hours. Easy.
They went around 9 yesterday now.
Please.
Dr. Kita.
Please. Oh. Yes, after Dr. Akitaju's lecture, Auntie Chidima was still calling us back. That woman. Our children don't grow up. She has grown up children. Nobody they disturb her again.
I get academic muscle.
You get academic muscle. Me, I don't get to. Now monetary muscle I get to.
And the battery muscle, solar battery muscle. You get battery muscle.
No mind that, it's because they sell solar. It's because they sell solar. You always get light 24/7. Hey man, are you too, man? I beg. So no be all of us they get light now. Like my area now, when we don't sleep, they go bring the light. When we wake up, we don't go see her again.
I do supply.
Madam Wachuku now.
Come and
Madam Wachuku.
If I dey do solar, now my house I won't put solar, not be rented apartment. I go see the money.
Where you live now, there you dey. You roof dey fall on top of your head, you go fall. So make it just Eh,
You and this Igbo proverbs.
yeah. So you must make yourself comfortable wherever you are. When you dey go, you lose all nuts and carry your thing on the water.
Abi o.
Na so.
No wahala, we go
Mrs.
talk now. You know,
Nwachukwu,
say
you are very right, you.
she's right.
Now where
Oh,
you
now
live,
where we
now
dey
is your
stay,
home
be
for
home
now.
now.
Oh.
Yes, now. If anything happen for the east, no be immediate effect. It go happen now for you now.
Na
Now
so.
Ibadan be your home now.
Na so. Na so. When they say pay security levy, and I mean go pay the first wey go pay. If anything
Abi
happen,
o.
na for the part e go happen.
Abi. If dem dey ask for the east, you go ask them wetin dem wan take the money do.
I
No
no go
wahala.
ask. I no go ask.
You no go ask, but you no
Una
go
wan
pay.
do the installation.
I no go
Me,
ask
the
wetin dem
install.
want to
Oh.
use money do. I go pay sharp sharp.
Mrs.
Comot face.
Mrs. Nwachukwu, me I be installer.
Sir.
Oh. I dey expert for that one. Oh. I dey
Oya
install, I
na
dey repair,
collabo
I
na
dey repair
let's
inverter too.
collaborate.
Mrs.
Let's
Nwachukwu,
collaborate.
I dey ask
I
for
get star.
training. I dey ask for training.
I get
Me
plenty.
I be businessman o. I be Igbo man
I
born
get
for
plenty.
Yoruba land o.
I get plenty installers wey fit train you.
Come and train me. Come and train
So,
me.
Mr. Fasasi,
Yes.
if you are serious about training, let me
I'm
know. I will
serious
get you
o.
a
I'm serious
certificate.
o. I want training.
I will
I want
I will
see
get.
abeg I need training. I need
Don't
to
worry. If you
expand
are
my
serious about
business
it, let
scope.
me know. I will let you know when the times come. So,
Okay,
and
I'm
you have
serious
the right
about it.
training with the right
Thank
people, with
you,
the
sir.
right
We get
company.
everything for
Yes.
this hall. For this hall, we get everybody. Everybody is very relevant and very
Yes, now.
professional.
Yes. So,
Yes, yes.
But I think to the envy you. You don't say that technology where you did. That the IMS thing. I
You
don't
know
know.
my company
don't
name,
worry.
Roy B's Solutions Limited. So we provide solutions.
I be I
For
like
any
that.
problem, we provide solution. If you want
I
buy
be
material, equipment, ICT
okay.
material, we are there. So let me join solar, join. So when you equip
It's
your
good.
hospital, I add solar to it.
I be now.
Ehen.
Well,
So it's good to relax before everybody goes out.
People are really
All
serious
right.
about business. So no one is even no one has even left the class. Everybody just stand back there.
Ah,
And I went on.
na money matter now.
Now you say
Like seriously, most of us we need to diversify a lot.
I tell
In
you.
Diversify.
fact,
We are
No
already
pray.
grounded in medical lab. Yes, we are already grounded in medical lab. It's a business we can go into anytime. We don't need special training for that. But we need to have other business outfit that will help us also. Multiple source of income.
yes,
We need to
yes.
advise
So
everybody just find something because age is no longer on
Age
our
is not
side.
on our side. Yes,
Like when I
yes.
you know I'm exit you.
So we should be building our retirement
Yeah,
empire.
it's not when they give us that chicken money that we'll start looking for. What do we, the suggestion will come start flying from up and down. Sell cement, sell block, sell container, sell what you no know. Make you no come put your head for business where you know sabi. The money go
You
fly,
get
come
it.
on, go buy.
You get it. So when we don't get business, if na this solar I can't learn well. I know
so
say I can
Madam
start
Nwachukwu.
selling.
God will help us. All right, so
I
Okay,
mean,
ma.
all right, ma.
All right, everybody, enjoy your weekend, though.
All right, sir.
So if Dr. Amuson said we will have a lecture or GST, let's prepare toward the evening. Once they contact me, I put it out.
Mr. Flex,
Yes, ma.
GST, we don't have
Uh,
material, no. What do we do?
Fasasi, what about
I
our
feel I
porter
don't
now?
need. No,
The
I don't
porter
know what you
has
do on
the
GST.
school porter has problem generally. I spoke with when I spoke with the dean, what he told me is that possibly they will give us a special account where we will pay into, and when it is time, they will remit it themselves. So I'm trying to work on that with him
Okay.
because it's
What
like we
about
cannot pay. We cannot pay. There's nothing you can do. You can't pay. The GST thing is there now. It's online, but you can't pay. And if you don't pay it, you can't pay any other thing.
And the tuition fee is still there.
We can't even access it because we can't access the GST, which is like the
And that's what I'm
developmental
saying. Now
fees.
it's not accessible at all.
It's
So
not.
that
It's not.
GS is
That's the
only that
problem.
compendium that we would need to read, Abby.
Then
Yes.
we are then we have
Yes.
to pay through portal now.
And the
But did
portal
he
is
give
not
us
allowing us.
assignments? Did he give us any assignment on
No,
Rwanda Clinical
no,
Pathology? Somebody was
no.
asking me. Okay.
Rwanda, I think he did though. Maybe I will ask him. He wanted us to talk about it, our own perception about it.
That genocide.
Mm.
It's okay. Please ask and let us know what his
Mm.
response will be.
God will help us. At least now we do the 400. We go do this one finish now.
For sure.
Mm. No wahala. Us know they refuse to go home now.
It is well, though.
Yes now. So enjoy your days, oh. Enjoy your
All
days.
right.